All right, so we'll be starting the seminar, and I'm just going to give Dr. Roy a brief introduction. So she's a vascular surgeon at Houston Methodist with a focus on limb salvage, but she does wear many hats. She's also a materials engineer and an imaging scientist, and she's revolutionizing endovascular procedures with imaging techniques. So she was educated at the University of Toronto, where she developed and patented a MRI method for imaging peripheral arterial disease without contrast. She's the co-founder of Magellan Biomedical, and she created CathPilot, a endovascular steering catheter. And if you just let me go on and on, I would take all day, but I will just let her out.
All right. Okay. Well, it's great to be back at EndMed. I've been here a couple of times. Some of you I know, some of you I don't. So just talking a little bit about my path, a little bit about what we do in the lab, but I do want to leave some time to talk a little bit about some career things. If you have any questions, I've done panels here before where some of the questions that you guys come up with were really interesting, more along the career advice route, things that I would have done differently and so on. So I'll leave some time for that at the end. But again, just kind of going through a little bit of this, I saw this article on EndMed saying, does the world need doctors with engineering degrees? And of course, I might be biased. I do think that the world needs more of us. So undergrad, I did the materials engineering med school. And then I had a really neat program at the University of Toronto where it was an 8-year residency. 4 years was devoted to clinical vascular surgery training, and then 4 years for a PhD, whereas I did the medical imaging degree there. So I think that the main reason why it's really important to have more engineers that are doing medical school is because of this issue, really understanding the clinical problem. I think that a lot of engineering only training programs, they do a lot of needs finding and tries to understand what kind of clinical problems we're facing. But nothing really replaces seeing that patient before you, encountering those problems every single day, and using that clinical problem as the starting point for your entire investigation, your research, your design process, starting with a really important clinical problem that matters. So the one that I've devoted myself to has been peripheral artery disease. So this is where you have plaque buildup in the blood vessels of the leg. And when you don't have enough blood flow to the leg, you'll have severe pain, wounds, they get infected, and about 1 in 5 will lose their leg in just a year from this condition. So it's a big, big problem, high morbidity and high mortality. So this is, when you have limb-threatening ischemia, 20 to 25% will require major amputation, and many of those will die. So it's a very, very serious problem, and one that we don't have great treatment options for. So right now, there's 2 primary ways that we can intervene on this. So how do we get blood flow down? We can either open up the blood vessels themselves. So under X-ray guidance, we can do ballooning or stenting. So we're opening up the blockage or clearing the blockage. The other option is rerouting blood flow around the blockage. So that's where we do an open bypass surgery to get blood flow around it. Very, very different treatment options, very, very different anatomic requirements for these. And we actually don't know who's best suited for what type of intervention right now. So this is showing you what an endovascular treatment option involves. So you have just a needle poke in the groin. We put wires, catheters, devices in the blood vessels under the X-ray, and we balloon or stent them open. That's very different than our large open bypass surgeries. These are 5 or 6 hour operations. We cut out the patient's own vein, sew it above and below the blockage. There's quite a bit of blood loss. Patients stay in hospital for at least 5 days and then often require inpatient hospital stays. Lots of wound complications. You often are doing this to heal a small wound on the foot, and then you create this big slash in the leg, and it's like, it ends up being a lot for our frail patients that often need to use this procedure. So most of us just try to do endovascular procedures first. So we figure we don't know who's going to be better suited for what type of intervention. This is minimally invasive. They go home the same day, and it seems like a great option just to try that first. But the problem is there's pretty high failure rates. So 1 in 5, you're not able to get through the blockage. And so now you have to bring this patient back. You have to do another procedure. And we know that if we failed once, our subsequent interventions become less and less successful. So this matters. Making this decision up front is important. And one of the big problems is that we don't really know enough about peripheral artery disease. We've largely just thought it was the same as coronary artery disease. So we thought heart attacks and the plaque buildup in the heart, that's going to be the same as the plaque buildup in the legs. Turns out not to be the case. So peripheral artery disease is very, very diverse. It's heterogeneous, and the materials that make up these blockages are very, very diverse as well. And so being able to differentiate these things are going to be important, because depending on what the blockage is made out of, your ballooning or stenting procedure may or may not be successful. But with current imaging, we can't tell any of these apart. So that was really what kind of inspired some of our research directions. So this is what you see with an X-ray angiogram. So this is currently our gold standard is this. You inject dye and you wait for it to get through the patent portions of the blood vessels. So you're not seeing the blood vessel wall itself at all. You're not imaging the blockage at all. Here, where that red dotted line is, it's showing you where the blood vessel should be. You see that it's blocked. You don't actually know how much of that is blocked, or whether it's just not getting down to the more distal portions. So this is what we're dealing with. This is the same imaging we've used since in the 80s, and we haven't really had much advancement here at all. We also will use duplex ultrasound or CT scans. But again, with calcified vessels, it's very difficult to see these blood vessels well. And they, again, don't tell us about the composition of the plaque. So our whole research program kind of started from this one very specific clinical question. So we know that when we're not able to balloon and stent, the reason because of that, where we fail is getting a wire across the blood vessel. So that's the first step for any of the ballooning or stenting procedures. You have to get a wire across, and often it's too hard or too stiff to get a wire through. If you can't do that, your procedure's done. So understanding that that's the most common mode of failure, we wanted to know whether we could develop new imaging techniques using MRI, because of its excellent soft tissue contrast, in order to differentiate those lesions so that we can tell you, okay, this patient, you're not going to be able to cross, you should go straight to bypass, or you may need better devices in order to treat this specific patient. So this is just a little bit of a timeline kind of going through. And I think that the reason why I wanted to highlight it this way is because we went from, benchtop studies with ex vivo vessels that we're looking through under a microscope, all the way to a clinical study, to developing new tech with a new company. And then now I brought our lab here to the Houston Methodist and have gotten some external funding. So it's just a nice pathway to kind of see how you can start from a very basic question and bring it to something that you can potentially clinically translate as well. So this is how we started to look at this. So we perform these amputations for these patients that don't have enough blood flow. We do them, quite frequently, and often those legs just go to the waist. But here we actually harvested those blood vessels and did really high resolution imaging using a 7 Tesla MRI. We had a custom coil. And the whole purpose of this is, how do we relate how the MRI signal behavior, how does that relate to the actual material properties of the plaque components? And so we found that there were these unique imaging signatures based on whether they're bright or dark on these two sequences. So the T2 weighted sequence, depending on that, we can differentiate things like fat, thrombus, and then smooth muscle, collagen, calcium. With those two sequences, we can differentiate all of these different plaque types, and we confirm that using histology. And then, sure, you can tell the difference. Does it even matter? Well, we're talking about the ability to get a guide wire across. So we wanted to say, do those imaging characteristics actually relate to the mechanical properties of the plaque? And this is how we tested that, where here, this is a motorized load cell where we're driving a guide wire at a fixed displacement rate through the face of the plaque, and we measure how much force it requires to get through. And this is really telling because, a lot of us, we can see calcium on CT scans and x-rays. So a lot of us will understand, okay, if it's calcified, it'd be hard. But there's a whole class of lesions that are pretty minimally calcified. It's this fibrous, hard, dense collagen, but it's invisible on x-ray. It's invisible on CT scan. So most of us who treat this every day didn't really understand the importance of this type of lesion in the first place. And with it requiring about 1.7 newtons, that's really higher than most clinical guide wires or off-the-shelf kind of workhorse wires will be able to generate. So this already tells you if you can identify these plaques, these are patients that would require something more than a standard wire that we usually start with. And then the soft CTOs only required 0.4 newtons to cross, and those are fairly easy to cross. And so why this matters is that we saw that not only the composition matters, but also where the lesions and the actual morphology of that is. So if you have calcium, it could be kind of lining the outside of it. So that's concentric calcium. Obviously, any wire is going to go through that, right? And so that would be crossable. If you have that same amount of calcium, but it's now a solid calcium nodule, that, is not crossable really with any wire, even really, really stiff wires. You can't get through that calcium nodule. But we found that even that same amount of calcium, if it's speckled in this dense collagen matrix, now this is something you can get through, but you really need the right devices for. So that's an example where we saw that if we can characterize these plaques, then these are things that we probably can treat minimally invasively, but we need to have the right devices on hand in order to be successful at it. If we don't know that, then you try a couple of times, oh, okay, this is not going to happen. We have to bring them back for a bypass. These are the type of patients that we started recognizing could benefit from advanced devices. So we then did this in a preclinical study. So this is now just an example of how we translated that, that we were using vessels. Now we image the whole amputated leg in a clinical scanner using clinical tools. Again, go through the painstaking process, but an important one to do histologic validation. And we were able to do that. So now we have something that we can clinically use. And then we did a pilot study. So at that time, we were using a 3 Tesla MR. We had resolutions of about a 1 millimeter isotropic, so not super high resolution, but the wires and the devices that we're working with, the wires, they're kind of 0.35 inch, so 0.035 inches, so that's about 0.89 millimeters. Like these are kind of the sizes that we're working with anyway. And often it's those kinds of bulk plaque characteristics that matter for the crossing question in the first place. But we were using prototype sequences and specific image processing techniques in order to make this work. We had blinded reviewers actually score each of the plaques based on their imaging characteristics on these 2 different sequences. And then we looked at crossability. Were you successful at crossing it? How fast was it? And this is just one example of how we can see if this clinically matters. Is this going to impact your procedural outcomes? And we did this at first in a very small patient set, had basically hard and soft in equal measures. But there was a huge difference. If you look at that p-value, huge difference in the crossability in those lesions that the MRI identified as being really hard versus those that are soft. Soft, you get in within 2 minutes. No problem. The hard ones, lots of variability depending on which devices you end up choosing. And also it's just we also had a lot higher failure rates. So we felt like we were on to something here. And this is now many years ago. And we're able to translate these techniques. One of the problems with MRI being able to really get them to be clinically adopted techniques is because every single one of those sequences or anything that you're using is proprietary. So to be able to use it on scanners across the country, across the world. You have to really tweak it and really use the right parameters depending on where you're doing that. So when I came over to Houston Methodist, I had to start from scratch a lot because I was working on GE scanners. Here we have a Siemens platform. Again, really confirmed a lot of the things that we saw before, but now we have a commercially viable technique with widely available sequences and showed that on multiple platforms, we're able to do this. And so this is an example where this is a lesion where you see a wire coming down with a support catheter and you see that loop. That's where we're bouncing against this really, really hard occlusion. And then when we balloon it, you see these tight, tight wastes that form. But on the x-ray, you see that it's completely invisible. So these are some of those examples of lesions that we didn't really appreciate before or couldn't identify them before. And on the MRI, the purple indicates that it's a really hard plug of collagen. We did a color coding just for ease of interpretation. And so those are kind of the type of lesions that we could identify. And 4 out of the 8, so half of them had little to no calcium. So these are pretty frequent. They have very high failure rates. And now we have an imaging technique that can identify them. Like I said, we have now done this at Houston Methodist. We just recently got this accepted, and we also compared our imaging techniques to some of the standard clinical ones that we use to score different lesions, and found that our MRI technique was more successful at identifying procedural failure rates and reintervention rates compared to what we have clinically. The other thing that was really interesting is that when we're usually using contrast-based mechanisms, what you're doing is you're injecting and you're taking pictures as the contrast goes through. As you can imagine, when you have lots and lots of blockages, they may or may not actually get to the patent portions of the blood vessels. And so it's very difficult to see exactly how long or how severe your lesions actually are. So there's this concept of hibernating lumens or occult lumens. And with the MRI, because you don't require any contrast, so this is just using the intrinsic tissue contrast that you get from the MRI properties of blood compared to the surrounding muscle, that you can differentiate fresh blood. And we were able to see these ghost lumens compared with the X-ray angiography. In this example, the ultrasound could pick it up as well. And then how this kind of ended up going to more of a device development side of things is now that we know that these plaque characteristics, they vary so much that we have a lot of devices that are commercially available, but the way or how effective it's going to be depends on what the plaques are made out of. And that's really what inspired some of the designs for our novel devices as well. So this is kind of from a standpoint of, we think that plaque morphology influenced the performance of the device. And again, kind of taking these as examples, if you have a concentric calcium, this is something you can cross with any wire, any device. This is going to be something that's easily crossable. If you have something which was speckled calcium in this dense collagen matrix, that was something that was not crossable with regular wires or devices. But when we used a commercially available RF ablation wire, this is really interesting that you could cross with this. So the company themselves didn't know that that was possible with this device. They thought, okay, if it's calcified, it can't get through it. And so it's like, when are you going to even use that device then? It's kind of a useless device because that was the only hard lesion that we were aware of. But we showed that if you have this speckled calcium within a dense collagen matrix, then that RF ablation wire, it can ablate that collagen and get your wire through. So now there's a clear indication of when to use a device like that. And so that's an example of a lesion that's going to be crossable with the right tools. And then those solid calcium nodules, those are not crossable with the RF ablation wire or really any other device either. But in doing so many of those puncture force testing experiments that we're doing and seeing this time after time after time, having your hands on it, we noticed that almost every lesion will have at least one area, a soft spot within that. And so it's not necessarily the right device, but if you have the right location, then you are able to cross it. So that was kind of the impetus for developing a novel type of steering catheter that we have. So this is a small startup that I have in Toronto where I did my PhD. And it was a spin-off device that we're still working on developing, but just as an example of how the insights in the lab really translated to something that is a novel device that we're hoping to get into the clinic soon. So yeah, that's the Magellan Biomedical. So that's the company. And the goal is really to help with our procedural times and reducing our failure rates. What you have, it's like a pull wire system where you're able to kind of isolate or probe different parts of the plaque. And there's a user interface where it shows you where you've attempted before. So you can quickly scan across the face of the plaque and find those soft spots to get your wire through. So if you just use like a conventional wire, you can imagine that you're kind of twisting the wire outside the blood vessel. And it just kind of whips around the periphery. And often the soft areas are really in the center, but you can't access that. And you're also just doing it quite blind. So with the Cath Pilot, it's something that we can quickly scan across the face of the plaque to find those soft spots. And if you're using things like RF ablation wires or things like that, that actually burn the blood vessel, that you really want to be precise about where you are in the blood vessel, it's a nice kind of adjunct to use. These didn't work, unfortunately, in terms of the videos, but it was going to show you like just examples of crossing attempts. But even novices can cross well with that. So in 2020, I was recruited down to Houston Methodist, and now I'm 50-50. So I do vascular surgery and have this lab. And I tried to really have my elective practice devoted to limb preservation patients. And I think that for yourselves, when you're thinking about roles in the future and how to integrate your engineering into your clinical career, I think that the only way to do that is if your patients feed your research and if your research feeds your patients. If you're, for me, I think that I needed to be really, really focused as much as I can with my clinical practice in order to make this balance work. So our mission is really to advance imaging, personalized treatments, innovate new interventions for this. We base it on failure, right? So that's another thing to kind of consider when you're thinking about what type of specialty to go into or what you want to do from here. Looking at the specialties that don't have great outcomes is probably a good place to start because that's where the needs are. So a lot of people think of vascular surgery and it's just like, oh, that's a terrible specialty because you have horrible results and it's very bad lifestyle and all of those things are true. But it's also a very, very fertile area for research. You know, my husband is an ENT. Gets great results and his patients go home and it's great. But for a researcher, you know, there's not as much room for innovation here. There's so much you can do. And obviously technology plays a big role in the future of the specialty. So something to consider as you're going through too. Looking for bad results makes your clinical life challenging, but it would make your research life probably a little bit more straightforward in terms of like the path forward. But so the way that we do it is looking for failure. So failure to cross, we talked about. Now, even if you get a wire across, how are you actually going to open up the blood vessel in a way that's going to be durable and not damage the blood vessel? Because right now, all we do is balloon. And you can imagine you're just blasting this open. It totally shatters the vessel wall. And then we wonder why it doesn't stay open for very long. Of course, the vessel wall responds to that injury and re-narrows over time. So nothing we have is durable right now because of that problem. And then the third thing is about how most of them do re-narrow over time. And being able to intervene again early involves having some surveillance that's going to be functional for these patients. So these are just some of the current selection tools that we were talking about. With X-ray angiography, all you can comment is the length and the degree of stenosis, and none of those scores have been associated with actual technical outcomes or procedural outcomes. So most of us don't even use it at all. They have really not translated to something clinically useful. And And this is some more examples of what I was talking about before, where you have these hibernating vessels, or what you're seeing here is there a pointer? Yeah. So basically, this is your iliac artery. Okay. It's completely occluded on this side. Okay. On the other side, you can see it's open. On this side, it's closed. So you can imagine below, you don't see any blood vessels highlighting, but you also have a big occlusion ahead of time. So you don't really know what's open and what's not. But with the MR angio, because you're not using any contrast and you're using those intrinsic properties, you are able to get slow flowing blood. And you see that is actually, there are areas of occlusions, but you can see these blood vessels below are all widely patent. They're just invisible. And again, below the knee, even more so, he's actually completely open, 3-vessel runoff. But on the X-ray angio, you don't see it. And this is a big deal. I've had patients that have undergone major amputations because the thought was that there was nothing open and there's no bypass target. There's nothing you can do for this patient. But really, it's the quality of the angiogram that you're doing and also not being able to really assess the runoff properly. So it makes a big difference to the patients. And some of this is not even known because we're taught that digital subtraction angiography is the gold standard, and that's going to be your perfect, that's the best imaging you have. So, yeah, this really matters. We talked a little bit about the CT and angio and how that differentiates and what we're doing with our MRI technique. So we call it an MR histology technique to characterize these plaques. And this is the one that we had published and it just got accepted for publication. So really repeating some of the things that we showed in Toronto, but that was all prototype sequences. You can only do it very specifically. It's one surgeon who was doing. Here, we're able to do this now with widely available coils, widely available sequences, and still able to show that we can find out who's going to have a high risk of technical failure, who's going to need more reinterventions, and how do we ultimately treat these patients more effectively. So that was the preliminary data that we submitted and were awarded an R01, and now we're doing this prospectively to develop this scoring system using our MRI methods in 100 patients in the next 5 years. We're also looking at some image guide or artificial intelligence type ways of being able to evaluate our MR methods so that we're able to actually do a lot of that interpretation for you. So MR, vascular surgeons, they hate MRI because it's very confusing. I get it. And so we want to make this easier and user-friendly for them to be able to pull it up in their clinics and actually use it to plan their procedures. So this is a step towards that. For the vessel wall injury, these are just some of the devices. There's been a huge explosion of all of these devices that have come out. So there's lithotripsy, and there's different types of drills and lasers and so on and so forth. None of them have shown any benefit over a plain balloon. And many of them have actually shown harm, where in the process of doing these kinds of more advanced procedures, you get all this debris that just showers down and actually increases your amputation rates. So a lot of the tech is out there, but not really, they're really designed for very specific types of lesions without the ability to differentiate those. You don't know who to choose and why. And this has been picked up by the media now. So this is the New York Times from July, and they said they lost their legs. Doctors and healthcare giants profited. Like there's lots of these from ProPublica and so on talking about how these types of devices are not proven. And it's really calling on these companies to have a higher rigor for that. And so really understanding what the right tool is for the right job. And we're exceptionally well positioned for that. So now we have developed this device development lab at Houston Methodist, where we'll do very high fidelity device testing. We do the MRI. We tell you what your lesion is made out of. We'll take your device, use it in an amputated leg, just as you would in a real patient. In our hybrid OR, we harvest the lesions. We'll tell you what it's made out of and what your device did to the blood vessel wall. And this is something that's really not available anywhere. So that's some examples of how we show you with with a control, when you, it's not working now, but basically in the first one where you're seeing, this is kind of a narrowed blood vessel, but it's one that has not been intervened on. So you have this thin layer of endothelium that keeps that vessel wall intact. That endothelium is really important because that's what keeps it a non-thrombogenic surface, right? When you strip that off, then you get a lot more thrombogenic properties and you're going to be more prone to restenosis. The second panel is where we have just a plain balloon angioplasty. So that is the standard of care right now. And we balloon open and it looks beautiful on our angio when we take our picture, but we're actually doing major, major blood vessel wall damage. As you can see, that whole calcium has lifted off of the vessel wall and has torn it. And then in this example, we showed an example where we used orbital atherectomy. So that's kind of a drill that sands the vessel wall a little bit to make the vessel wall more compliant, such that you can balloon it with a lower pressure balloon inflation. And for that one, we did see that you don't have that same huge fracture of the plaque, but you do end up having to strip off that endothelium. So what's the long-term implications of that? And with our MRI techniques, we can actually image patients safely again after the procedures and follow it. So we see what the blood vessel does to responds to the individual treatments. But these are some examples. And then this is the drug-coated balloon. So I mentioned that 70% will re-narrow in just 3 months. So what manufacturers have done is now loaded it with paclitaxel, which is a chemotherapeutic agent. What that does is it kills replicating cells. And so the idea is that it'll decrease your restenosis rate that way. But what it is it's just that powdered or crystallized drug on a balloon. You balloon it and you remove the balloon, right? You inflate, keep it up for 3 minutes, deflate, take it out. And less than 10% of the drug is actually getting to the vessel wall. So most of it's getting washed off as you transport the balloon to the vessel wall. And then when you balloon and bring it out, a lot of it gets showered down. And again, there's some link with higher amputation rates, and some of those solid crystals are getting distally embolized into the small arterioles, and that could be causing tissue hypoxia and damage. So we're looking at that with scanning electron microscopes, seeing how we can improve this drug transfer rate with a novel design. And so we have Kelvin and some people from our lab who is helping us design that balloon. But I think that one of the really unique things is, one, being part of the solution, because you're working with commercially available devices, telling manufacturers what's wrong with them, how do we make this better, how do we make it safer and more effective. But also, again, that failure piece, understanding how and why we're failing, can help us develop the new devices and really have unique insights with which to guide our approach. And that's kind of, again, that's some more recent data. So with the device development lab, we got a transformational project award from the American Heart Association, and the second aim of our NIH award. They both use the same cadaveric model to test various types of devices, and it's been a really successful program that's growing. So if you do have any interest in those types of experiments or things along those lines, please give me contact me, because we're working on these. We have these amputated legs at least twice a month or so, and we're doing these experiments very frequently now. So if you want to be part of that, I think it's a really valuable experience for some of the students that have come and joined us. And then for the re-narrowing surveillance, that's more looking at wearables. So there's these flexible ultrasounds now that we're looking at how we can use that and implement that into our patient surveillance, so that we can catch these re-narrowing early and intervene early as necessary. So I just wanted to kind of talk just kind of wrap up here a little bit, because I think that the thing that's guided a lot of our work is just looking at failure, how we're failing, why we're failing, and how do we reduce that. And with that, we can improve the success. So the little drawing up at top, that's the Fogarty balloon, the patent that they had. And I just think that it's just a really inspiring time to be part of vascular surgery specifically. That's what I know. But we can actually be true pioneers that changes how we're treating patients and actually making a difference within our career. And I think it's just a very exciting time, and being in your position right now, being part of it and really using your engineering degree, using that in your next steps is going to be very important for us to improve our success rates going forward. So, I just wanted to thank many, many people who are contributing to that work, and happy to take any questions you might have.
No, most in vivo clinical scanners are currently limited to 3T.
Yeah.
I know like most hospitals only have 3T scanners or 1.5. Do you see, like, if you could say there were 7T scanners at every institution, do you think that would help, and how so?
So, I actually came to Houston Methodist because I was like, oh my gosh, they have a whole bore 7 Tesla MRI. This is going to be great. And now we can do super high resolution imaging. And so I started using that. And as you increase your field strength, you also have a lot more sensitivity to different artifacts and homogeneities and so on and so forth. So actually, I find my 3T images better. So I'm now at like a 0.5 resolution. So on the 7T, we're like 0.2. But because the actual image quality is much better and you're not as prone to motion artifact and everything else, I've actually used the 7T a little bit less. I do use it for some of our cadaveric work where we're really, really wanting to see, okay, what did this device do to the vessel wall? So I think for research purposes, that'll be, that it's helpful. But for more clinical application, I don't think it's as helpful as I had thought it might be.
Just a question on like how like calcium forms. You mentioned that there's the concentric rings versus the diffuse versus like the large just chunks of it essentially.
Yeah.
Is there any like cues to you of like who is going to form these concentric rings versus who is going to form like the diffuse calcium? Like is there anything that can cue you in on who is going to form which type?
So the only thing we can use is some information from the comorbidities, right? So we kind of see that like lead pipe, concentric, eggshell kind of calcium. We usually see that in end-stage renal disease, kidney patients, and so on. And we also see those same types of calcium when patients take warfarin. So there's been an implied mechanism where it's like a vitamin K dependent mechanism where it's inhibiting your calcium inhibitors, and you get this pattern of calcium. But, honestly, I don't think anybody's really looked at it or knows about it. The fact that there are these many different types of calcium, it's all very, very new. So we're looking at doing some spatial transcriptomics on some of this to get an idea of whether we can differentiate, whether there's specific genes that are upregulated in specific types of calcium. Ultimately, I think that what one thing is I'm a surgeon, so I balloon and blast things open. But I think ultimately the thing that's going to be most successful is going to be something medical and drug repurposing libraries and so on and so forth. I think that that's kind of where the future of this really lies, but it really requires us to understand this better first.
So forgive my ignorance, but why is stenting not used in these peripheral vascular interventions?
So, it is used in the above knee segments. In the below knee segments right now, the stents are not approved. So we will sometimes use coronary stents off label, and it's because the FDA didn't approve it because they block. I think that it's often a low flow state. These are 2 millimeter vessels or so. With these really calcified lesions, you can imagine your stent apposition is not going to be great either. And so it's been an ongoing problem in the below the knee segment. And that's the segment of the population that's just exploding because diabetics and renal disease patients, they typically have that pattern of disease.
So, really quick question. So, I feel like going from the angiogram straight to amputation is a bit of a jump. So, like, what other decisions are physicians making to go for like below the knee amputations? Because I know like there's a whole like clinical presentation for acute limb ischemia, but like it feels like quite the jump. So,
Yeah, well, some people don't even get the angiogram. Like, so you'll see that there's a really high variability in amputation rates depending on where you are in the country, who's doing it, all of that. So me personally, the things that I'll use is so clinical exam, like if you have a palpable pulse just proximal to the level of amputation, that's going to be your most sensitive marker. That's typically not the case for our patients. Like we usually don't have that. You can use things like transcutaneous oxygen and so on, but those also have not been that, reliable. You can have skin temperature, that gives you a sense as well. But really, it's not a precise thing. And so that's why you'll have two of us do an angiogram and we'll both have very different plans for that same patient. And we're in the same, these are my own partners, right? So you'd think that it's more of a science than it actually is right now.
So you had mentioned that there's the different types of plaques that can form in the arteries. And then you also mentioned that drills or like those drill-like devices in the past, when they've been used, they didn't account for those differences. Has there been any updates in like studies that like kind of correlate specific types of those occlusions with like better probabilities of success when you use the drill, or has it not really been tackled yet?
No, so the problem is that the only thing that people can comment on in terms of plaque is calcification. So there's some where they're like, okay, if it's super heavily calcified or, it may, so for example, the drug-coated tech, there's been some evidence that if you have concentric calcium, that's going to have worse outcome than if it's eccentric. And the idea is that it like acts as a barrier for the absorption. But because you can't see all of these other properties and you can't tell the other plaque characteristics apart, none of that is factored into our literature. So often the only thing we're doing is we're saying, okay, device is used here, amputation in a year. There's so many different things that will, kind of vary depending on what's going to be successful or not. Like, is the patient taking their antiplatelets? Are they smoking? Are they, there's so many different things and none of that's going to be captured. And so I think that that's been a really unique thing for our device development lab, because now we can actually show you what your device is doing to the vessel wall. And that's been a big gap.
And you said you mentioned that you're using a specific like pull sequences for like MRI, and I know like MRI is one of the limitations is that it takes one of the longest in terms of acquiring the image. How long is that taking for the image that you showed us, for example? How long is that taking, and are you using or are you intending to use in the future any like acceleration sequences? So is that a limitation?
I think that certainly it takes longer than a CT scan, for example. And what we're doing right now is that KISS sequence is the one that I'm using for just the angiogram. That's fairly fast. That's a few minutes. You'll get the full arterial tree. But for the actual plaque characterization, often what I'll do is I'll kind of like use that sequence to identify the area of the plaque that we're wanting. And then we'll go in and use the ultra short echo time sequence for that area specifically. So that can be like a 10 centimeter long segment would take about 5 minutes. So it does take some time. But I think that is very amenable to a lot of the acceleration things. Like these are pretty sparse data. Like, it's like, and so I think it actually would be amenable to that, but that's still not something that we've implemented just yet. We're looking for something that's going to work consistently first and then, speed it up as we go.
For the drug-eluting stents, that 10% of the actual drug being administered to the vessel wall, I thought that was kind of shocking.
Yeah.
I was curious how you figured that out and then what you propose as like potential solutions.
Yeah. So just to be clear, the drug-eluting stents, those ones, they have like a reservoir that's next to the vessel wall. So that doesn't have that issue. These are for drug-eluting balloons. So the idea is that you don't want to have anything left behind, right? The stents we had mentioned are not really indicated below the knee. So it's just you inflate, remove, right? And then that 10% is actually from some of the like benchtop literature that's out there. And for us, how we're looking at how much is getting transferred to the vessel wall, we're doing it with the scanning electron microscope. So we'll inflate the balloon within the vessel wall, and then we kind of slice it in half so that you see the face of it. You coat it, and then you do the scanning electron microscope, and it'll show you the crystals and how much is there. And we saw that, like, if you have this really, really nodular plaque, because of the areas that it only like touches the hills and none of the valleys are getting any drug, right? And so that was something that we saw. And versus when you have like a very smooth surface, you get better drug transfer. And so that was kind of the impetus for some of the designs that we're doing, where we're developing another type of balloon, which has some plaque modifying methods as well, and can help with actually increasing the contact pressure so that you can get more drug to the vessel wall. So something that we're working on with the Rice Capstone project, and just put in a provisional patent. And so it's still very early, but we're working on it.
Hi. So you said there are some differences in like the atherosclerotic phenotype in like the peripheral artery space versus coronary arteries, and also like differences in treatments and successes of those treatments.
Yes.
So what are some of the like additional challenges that you face in kind of peripheral arteries, and also like barriers to innovation within that space?
Sorry, what's the question? We definitely have additional. Oh, why is it more challenging?
Yes.
Okay. I think that one is the type of lesions that we're dealing with. So if you see that before we had a lot of smokers, that's a lot of atherosclerotic. Those patients actually seem to do better with some of these interventions. Okay. So I think it's the type of lesions that we're dealing with, the length that we're dealing with. So with coronary interventions, these are like kind of very short, like, it's very short. For us, we're dealing with really long lesions, and that's a big challenge, right? And then, I would say like that's often those two things, like not really like having different type of composition and the actual length and complexity of the lesions that we deal with, it's just much worse. So that's why. And also, there's like a million cardiologists. There's very few vascular surgeons, so it's an understudied area as well.
Hi. The plaque characterization with the MR looks pretty cool. That reminds me of the virtual histology ultrasound.
Yes.
So have you compared how those two, like, what's the benefit or pros and cons of each, or why the ultrasound is not in your consideration?
Yeah, no, I use IVUS as well. So with the MR, a lot of this is about how do we select the patients before they even get on your table, right? We want to pick the right patients, pick all the devices, size them, have three-dimensional imaging, cross-sectional imaging, all of that beforehand in a non-invasive way. So with the IVUS, I had mentioned that the main failure issue is not being able to get a wire across. For you to get your IVUS across, you need to get your wire across. So already you've kind of like, it's already a subset of patients that you've already, surpassed the main hurdle for. So it's not that I don't use it at all, but it is an additional step. And if I can avoid all of that altogether and just go straight to bypass because this is this long and like a dense occlusion, then I would do that versus trying to struggle with another intravascular technique. That's what I would say. I don't think it's in replacement of that. I think it's a different purpose for it.
Questions?
I just had a few questions on the UTE. I'm not quite familiar with that. Did you have longitudinal data that shows these plaques evolving from one state to the next, or do they pretty much stay stable in the patients during the time frame that you're seeing them?
So we didn't have the UTE images like serially. We are doing that. It is very difficult to get patients to come back for for more imaging. I'll be honest. Like, so that's been one thing. But what we did have was looking at the reintervention rates and restenosis rates. So that's with ultrasound, where we follow them after an intervention. And you do see that the ones that we found were those really hard plaques. They had higher restenosis and reintervention rates.
And does that technique also, are you able to sort of age stratify thrombus as well? Because as opposed to like the acute and subacute thrombus fibrin levels, and then ultimately ending up in this collagen sort of.
Yeah, so that's actually what we're doing now for the DVT space. We're looking at comparing the UTE characteristics to the clot composition. So when we do DVT thrombectomies, we're extracting some of that clot and doing ex vivo analysis. I think a lot of the MRI techniques that have been used for aging clot has really focused on iron content and composition and transitions. But I think the UTE may be more relevant for us because of its ability to actually indicate the collagen content. So we're kind of taking a different, I think that there's been a lot of work on MRI characteristics and aging of clot, but I think the UTE specific ones have not been investigated, and we're using a lot of the arterial techniques and trying to apply it in the venous space for that reason.
Okay. And last question, is that a common sequence available on almost any scanner that has a vascular cardiac package, or is that a separate sequence that you have?
No, so now for the Siemens one, the Petra sequence is the one, and it's usually a stock sequence that most people have. Before I was using kind of prototype 3D cone sequences, and I do have another works in progress sequence that we use that are probably a little bit better, but the Petra sequence, it works and it's available. It's just not as good. The echo time is still a little bit longer. It's about 70 microseconds. And some of the works in progress sequences, it's like 30 microseconds. And that gives us a better differentiation between the calcium and the dense collagen. But these are kind of, minor things. So I think I think that it can be improved, but that's kind of the one that's available.
Great. Thank you.
Yeah.
All right. If there aren't any more questions, thank you, Dr. Roy, for an excellent presentation.